YNS, because he knows anatomy, the whole anatomy, and I think it may help to understand the surgery going well. Also, another guy that is maybe I think Albert Belletti, the year student, so Alexandro Barro. Just we are very much eager to listen to his AI lecture. Thank you very much. We're very much happy to hear. Thank you.
Thank you, Professor. And so let's move on with the first lecture. I have actually a great pleasure to introduce Professor Luis Borba, Professor and Chair of Neurosurgery, Federal University of Paraná, Curitiba in Brazil. I think Professor Borba does not need a very long introduction. He is very famous. He is very well known for his huge expertise in all neurosurgery, but in particular about skull base. He has also been president of the Brazilian Society of Neurosurgery and of the Neurosurgical Society of Paraná. I had the privilege to meet him a few months ago in person in Sarajevo and to listen a great lecture by him. So thank you, Professor Luis Borba, for joining us today. Professor Borba is going to talk about jugular foramen, a neurosurgical playground. So Professor Borba, please, you can start your talk.
Okay, Alberto, thank you very, very much. Can you listen me well, yes?
Yes, we can hear you.
Okay. Thank you, Professor Cato. Great opportunity to join this wonderful webinar in the Fujita University. And let me try to share my screen here. Let me see. Okay. Can you see my screen?
Yes, we can.
Yeah, okay. I work in Curitiba, in the south of Brazil, in the state you have a lot of Japanese there. I think São Paulo and Paraná is the two states who have more decolonization from Japanese people. You have many partners in neurosurgeons that originate from Japan. It's not allowing me to go. I'm not moving.
There is a small button on the left side of the...
Yeah, okay.
Fine.
Not good. Okay. I will mix this presentation some philosophical way, some the way that I'm seeing the medicine and the neurosurgery today. Today, you talk about a new era of treatment of patients, technologies, new instruments, a lot of information, the diagnosis precise, new techniques. And when you see in the best tuners in the world, you see, you need multimodality treatment. We need every equipment, every people. But one guy is missing in this crowd. Is the patient. Sometimes the treatment that you are offering to the guy in different pathology, in different place. The most important that is the patient is missing. Take a surgery, 10-hour surgery, time consuming a lot. Today, maybe not possible. Why? If this may be the best for the patient. I will talk about my experience in tumor of the jugular foramen in the temporal bone, the majority of them of glomus jugulare tumor, and the way that's changing, they are seeing this kind of pathology, especially skull base, especially in temporal bone. The temporal bone surgery is the only one that reproduces what you learn in the lab. It's the same thing that you do in surgery, because it's bone. And the bone you can reproduce totally. When you see the complex anatomy of this area, the facial nerve, the internal jugular vein, the sigmoid sinus, the vertebral arteries, the ICA, the middle ear, you think, oh, it's impossible to work on this area. But if you go to the lab and spend your time learning the anatomy, how I did 3 years of my life, I should stay more, I think so. And more every day I have doubt about the anatomy to learn in every presentation that I see the people talk about anatomy. When I see this young generation that go to the lab and show beautiful dissection and beautiful new technique and approach, came to my mind and came to my soul the wish to come back to the lab again. Was the best time of my life that I was learning every day new things. And this time that I spent in the lab, I'm sure that was crucial to help in my profession as surgeon, especially to help my patients. Today, you see a tumor like this that's very small, located in the middle ear, that every ENT of the world used to do it. Now the people are afraid to do it. It's very complicated surgery. It's very bloody surgery. But during many, many years, you did this case and removed the tumor with good results. Now looks like there is a new era of treatment of skull base, and especially in the jugular foramen area. 90% of the tumor in the jugular foramen are benign tumor. And the best way to treat a benign tumor is take the tumor out and cure the patient. The radiation for glomerular tumors is a very old technique, since the 60s, 70s. Of course, the radiation therapy improved. The complication is much less than before. The technology showed that you can give more focal radiation, but the biologic effect to the chief cell, that's the main cell of the paraganglioma, is the same. Cut the vascularization, but the chief cell is still alive. This was said during many, many years, and still you know today. Today is the area of systematic review, meta-analysis, something like that. Everyone likes to do that, because it's easy to publish. Systematic review and meta-analysis. Citation is very large number. But how can I compare a surgical skill that are completely different? How I compare my aneurysm surgery with Professor Cato's surgery? He has much more skilled than me to treat AVMs and aneurysm surgery. Of course, her results will be better than mine, because she prepared, she trained more than me in vascular surgery. I cannot compare it. If I cannot put in the same pocket the guy that treat one case while another guy treat 100 cases, will be different. This you need to understand. This meta-analysis about glomerular tumors is very, paragangliomas, the head and neck, not glomerular, show very interesting. 1,117 patients, 1,144 tumors. Glomus jugular is 900. Glomus tympanic 90. Carotid body, 30. Glomus vagalis, 16. Okay, a large number of cases. In these meta-analysis, they treat radiation, stereotoxic radiation, as a primary treatment, 57%, as secondary, 36%. In 6%, they had no idea what type of treatment was did. No idea. In 20%, they have no idea which side was operated, was irradiated. 20% in the meta-analysis has no idea which side of the tumor was irradiated. But they know that 90% control. I had no idea where I irradiate, which side, which technique you use, but 90% works. This is difficult to understand when you go to the literature. In the volume, 8.5 millimeters mean, 2.57 to 56. Is complication, of course, every kind of treatment has. Also, radiation. Can malignize? Of course. You always should say to the patient, it's not often, it's very rare, but can happen. Radiation therapy, malignized tumor is described in the literature. It's very low rate, but you need to tell to the patient. Today you see in the world that people say that, oh, you go there, you do treatment in the morning, in the afternoon you play golf. It's not fair with the patient. But when you talk about surgery, oh, very difficult, very complicated. Let's talk to the people the truth. You have a case like this that I showed in the beginning, very small lesion. You do a surgery, facial recess approach, just understanding the anatomy. You open the tympanic cavity from below here and take the tumor out. And go home. No radiation, don't need anything that the patient cured. And to put the tympanic membrane out. The ENT used to do this a lot. I don't know why they don't want more. They want to do cochlear implant. Maybe it's better to do cochlear implant than spend some hours to remove this tumor. I don't know. The medicine is changing, the life is changing, or the business is changing. We as doctors, you cannot think as business. You need to think as doctor to treat patients. In that series, the majority of the tumor was this size. But what you see today is not tumor like that. The majority of tumor that you see in the jugular foramen area are like that, a large tumor. And in South Asia and in South America, the majority of tumors like this are very large lesions. How are you learn to treat this kind of big tumor if I don't know how to treat the small one? That I go to dissect, that I can understand the anatomy, and I can see and remove this small tumor. How I can treat this big and large tumor? A case like this, a patient came to me, facial palsy, deafness, and hoarse. It means 7, 8, 9, 10, 11, and 10, 11, okay? But he also has had 11 and 12. He had 2 tumors, 2 big mass, one in the jugular foramen, other one in the neck. What do? Irradiate up, irradiate down, send home to die? You are doctors. You need to treat this patient. To treat, you need to train. To train, you need to dedicate. We did surgery. You came in the neck. You remove the big mass, the carotid body. There's a very nice plane of the vessels. You see the external carotid artery, the internal carotid artery, the common carotid artery, the hypoglossal nerves, and you take this big mass. And you can stop the surgery here, or you can continue to the other part, to the other tumor. I decide in this situation to continue the surgery and go see and pray. Tumor here, no more tumor. I decide to continue the surgery and go up and remove the tumor also that was located in the jugular foramen and identify the facial nerve, do the reconstruction of the facial nerve, the greater auricular nerve that is in the field during the same operative time. 10-hour surgery? No, 14-hour surgery. But we try to do our job. And went there and remove the tumor, facial canal, mastoid tip, facial nerve, lower cranial nerves, tympanic cavity, reconstruction of the facial nerve. In the post-op, you did like that. You remove both tumor in the neck, tumor in the jugular foramen. Long time surgery? Yes. Long stay in the hospital? Yes. But this 34-year-old boy or man now can he give his life. You give one day of your life to try to save the life of the patient. It's our goal as a doctor. Now is coming a new modality for jugular foramen area, very complicated area. Embolization as a primary treatment. You go there, embolize, and go home. And now came new ideas. Everyone with one new ideas. Look this patient here. A patient from Uruguay, 23 years old lady, 3 embolization in 4 years. And the tumor, what was difficult the first time, they tried to do embolize. And now the vascularization of the tumor is like that. It's coming vessel from everywhere, from homolateral ICA, contralateral ICA, ECA homolateral, ECA contralateral, vertebral artery. The tumor that was very difficult to remove before, time consuming, now is almost impossible. And the embolization by itself is not so benign that you say. In 5 to 20% to have new deficit with embolization. Because you need to understand that every kind of treatment that you do, you can have complication. You need to work. See, it tells the truth. And big case that is had there, we did surgery, we did petrosectomy, but still remain a small piece of tumor in the midline that I couldn't remove by petrosectomy. In this case, I sent to radiation. This is a small piece that was left there. Maybe it was the first time, if the primary treatment was surgery plus embolization, not only embolization, or surgery alone could be much better result than you have now. Another situation like that, sorry for the thing, but I want to show this. It's crazy. A beautiful Brazilian lady from Rio de Janeiro, 30 days, vertigos, dizziness. With permission of her, I put her picture. They found this mass. They decided to do the biopsy and embolization. Perfect. The patient post-op was good. The tumor came back. They did a second embolization, and the tumor continued to grow. No, it should be okay. The vascularization, the patient, this tumor is very low growing. There is no problem. The people say like, to the lady. And the lady came like this later. This beautiful lady now has a facial palsy because the tumor invaded the facial nerve. Was completely different history here. We have a localized tumor in the jugular foramen going up to the middle ear. Then now you have a tumor like this that invade all the middle ear and invade the facial nerve. Independent of the treatment that you do for this facial nerve palsy, independent of type of reconstruction that you do for this facial nerve, this lady never will be the same. And we lost the opportunity. Do you know why? Somebody told her, if you do surgery, you have tracheostomy forever, gastrostomy forever. It will be terrible. And this lady disappeared. But the people didn't know that if you need to understand the tumor by itself, if the patient has no lower cranial nerves in the pre-op, if the lower cranial nerves, the swallow function is okay in the pre-op, in the majority of the time means that the anterior wall of the vein is preserved, and the nerves that are crossing over this anterior to this wall are preserved. And you do surgery and you can preserve this anterior wall. You see like that, the jugular bulb, this bleeding that is venous bleeding, but the nerves are anterior to it, and the tumor is out here. And this beautiful lady that somebody told her that she would have tracheostomy and gastrostomy forever, in the post-op is like this. Is eating very well. And you get a nice, good removal of the mass. We lost, in this case, the opportunity to save this beautiful face. Embolization as a primary treatment? Never. Embolization is adjuvant. If the patient has pre-op lower cranial nerves preserved, if the swallow is okay in the pre-op, I prefer to wait and don't do embolization. Because if you do embolization, maybe you damage the nerve in 5 to 20%, and it be more difficult to remove. Not embolization to everyone. Select case. Pre-operative deficit, large tumor that maybe you have problem, but not to every case by case. And the man, the human being, has always the capacity and the imagination to create new techniques. And now came this hybrid, minimally invasive radiation plus embolization. Man, it's nice. The name is very nice, hybrid. Hybrid, minimally invasive. It's good. Maybe for a Hollywood movie, you see, would be a very nice Hollywood movie. Young guy like that had a small paraganglioma from the vagus, hoarseness, and swallow difficulties. And the idea was like that. put one stent in the ICA, another stent in the ECA, and irradiate with cyberknife. See, hybrid treatment, hybrid idea, cyberknife treatment. See, it's for Hollywood. What this idea? See, look, man, very nice. What's happened? 3 years follow-up. The tumor is still the same size. The ICA is thrombosed. The ECA is thrombosed. But the patient is okay. He was 43 years old, good collateral. He is okay. This is a good idea? I don't know. Maybe the best should be wait. In Vagus paraganglioma is different than glomus jugulare or carotid body. In Vagus paraganglioma, you need to be patient. Wait the tumor eat the nerve. When the tumor eats the nerve, the other side compensates, and you can do the surgery and remove the tumor. If you do the surgery for vagal paraganglioma, with the patient with no deficit, the patient will wake up with facial, with lower, with 10 vagus nerve deficit. That will be terrible. You have to be patient. Talk with the patient, explain to him, and wait. See? God will help you to do this work. Come from the other side to this side. Facial nerve management. The greatest man in the jugular foramen area was Professor Hugo Fish. I think the best otologist ever. His school is all over the world. But he was doing the same technique for every case. Anterior transposition of the facial nerve and expose the area. And he shows that in his series, 100% of the cases he recovered totally the facial palsy. But we know if you have a facial palsy, the majority of the patient recover, of course, but some spasms, some tic, something different happen. The best way to treat facial nerve is leave the facial nerve in anatomical position. Because this is, you described this years ago, the way to work in the jugular foramen, keeping the facial nerve in anatomical position, work anterior and posterior to the facial nerve, work anterior and posterior to the facial nerve, but keeping anatomical position, and close the externatory canal and follow the ICA, or in extreme case, to do the transposition or the reconstruction of the facial nerve. Case by case. There is no standard approach for jugular foramen. Is a case like this, facial nerve palsy, hearing deficit, a mass, not so big, but the tumor was going up. You can do the surgery, you can expose the facial nerve, you can stimulate to see if it's totally paralyzed or not. You can come proximal, can come distal, you can open the nerve sheath, identify that the tumor is invading the nerve. You can come like that. You can harvest the graft in the great auricular nerve that is in the field. If you don't have the graft in the field, you can take this from the sural nerve. You remove the part of the tumor that is invaded by the tumor. Try to keep the sheath and find the proximal normal nerve and the distal normal nerve. This is the part that was invaded by the tumor. You go there and do this. You clean, you remove more mass. You still have more mass in the middle ear here. You go and remove this small piece that was in the canal. And after you remove this, you take the graft and just put over the nerve and glue distal, glue proximal. It's done. You can do the tympanoplasty. If you have a nice ENT work together, is very good. Very, very good. If you have a nice ENT, I do by myself, you know. But if you have a good ENT, it's a good idea to work together and put back and try to preserve the hearing as it did in this case. This is the immediate post-op. The lady is still in the hospital. She can eat. This is the lady almost 1 year. This is the lady 1.5 years. See, it's not the same, but it's okay. The patient has severe deficit in the pre-accuracy, no more mass. Another situation like that, same thing, re-op, was operated by somebody, came to me, a tumor like this, you have this large tumor, we do the surgery, you remove the mass, maximum that you can, it's a big mass like that. Now you reconstruct the facial nerve. Here's the nerve in the parotid gland. In this case, I use the sural nerve because I had previous surgery. Find the nerve in the posterior fossa here and reconstruct the nerve, the facial nerve, from the posterior fossa to the parotid gland. Just one stitch. You can put the graft. And post-op, immediate post-op, almost 2 years. You had the lady here. One side, the other side. It's possible? It's possible, but need to try. Radiation therapy is a good idea for some case. This same case that I showed before, 12 years later, this case, 12 years later, had recurrence. In this situation, I decide to send to radiation therapy. There's a small residual tumor. Why I didn't come back? Because it's very difficult to come back in this area. The anatomy will be very complex, very distorted, will be difficult to identify. Now she has 3 years follow-up. The tumor didn't change. It's not bigger and not smaller. It's still there. Natural history, I don't know. It's still there. Just wait and see. The biggest issue in glomus jugularis surgery is not to remove the soft, bloody tumor, it's the bony invasion. This part of invasion is the most difficult part. Looks like a chordoma that is bloody chordoma, very bloody chordoma. Familiar issue, a large tumor like that, we did surgery, we remove maximum that you can, remain one small piece of tumor here. I couldn't remove totally. I sent radiation therapy. This is small piece. See, not too small, but I prefer to treat this part away from the brainstem, away from the nerve, radiation therapy. It's the pre-op, this is the post-op. Gamma knife versus cyber knife, I don't know. Time will say. To finalize, I'm gonna show you the impossible tumor. Secretive tumor, because this you need to organize very well the situation. This patient come to me, tumor like that, no hypertension, facial palsy, It's a large tumor that was growing, and growing. Vascularization from everywhere. We tried to do the 3D reconstruction to understand the mass. The dopamine was 2,500. Epinephrine was normal, norepinephrine was normal. This case is the case that the patient, the blood pressure go down, is very difficult to put up and very difficult to control. Several cases reported in the literature say that the patient died in the OR. What I did, oh my God, what I do this big case? Leave this guy die? I sent to embolization. The embolization was okay. I decided to do surgery. The surgery was, believe it or not, there is no blood, no instability like that. You remove totally the mass. You see the here. Post-op is complicated. You have some edema here. 30 days in the hospital. But after 30 days, the patient, 90 days, the patient come to your office like that. You save his life. And dopamine now is normal. The MRI is normal. In skull-based surgery, in jugular foramen surgery, you need training, but you also need to believe that you can large tumor like this, that you like it. But neurosurgery, you need to be passionate, you need to have pleasure, you need to like that we do. I love to eat. I like a good wine. I love football, the Brazilian team, the best team in the world. And you need to love neurosurgery. You don't love how to do it, you never get situation like that. Ours will be a difficult situation. Thank you very much, Professor Cato, for the opportunity. Thank you very much, Alberto, and sorry for the long time.
Thank you, Professor Borba. Thank you very much for this wonderful presentation about a very difficult pathology, actually, and very fascinating. I think we can open the discussion. So if there are questions, okay, issue.
Yeah, thank you, Professor. Thank you so much. It was a wonderful presentation, and I really like the way you presented the whole presentation. At one time, you were very clear in your concepts. So first thing, I want to congratulate you for your beautiful presentation. And you have oversimplified the cases with your technique and the way of presentation. Now coming to the question, like you said that select the cases for embolization and mentioned two criteria, that one is neurological deficit, and second one was the large size of tumor. So like any other cases in which you specifically ask for embolization other than these two criteria, you go for embolization and then go for surgery?
Do you know, the majority of the vascularization, the glomerular tumor, is coming from the external carotid artery.
Yeah.
And the vascularization of the nerves is from the external jugular artery, the ascending pharyngeal. If you embolize, maybe you embolize the nerves.
Okay.
Because this, when the patient has no deficit in the pre-op, and the tumor is not so large like this giant tumor,
yeah,
I prefer to not do it. In large tumors, the majority of them are the patient already has deficit. It's very rare the patient don't have deficit if large tumor. The criteria that they use the majority of the time is like that. See, the other point that I use in this case, this dopamine case, was like I was trying. I remember that I called Dr. Omefti, and Dr. Omefti had one case before, came from Saudi Arabia here, that dopamine secretion. And he said, oh, I cannot do surgery. If you do surgery, the patient will die in the OR. But I have that guy with dopamine secretion. And I had the crazy idea, I don't know if it's crazy or not, they said, let's try embolize to see what's happening. See, because the embolization will change something in the tumor.
Yeah.
And he did the embolization, see, and was okay. I'm thinking now that the patient who has produced hormones is one option to do preoperative embolization. Maybe the patient will be more stable in surgery. I think is one option. But for a small tumor, the problem that you see around, the people embolize every case.
Yes.
The tumor become a rock. I did. I tell them that I did. I embolized a lot. I sent to embolization many, many times. And the tumor become a rock. And it's happening in Latin America. Don't happen in Japan, don't happen in Italy, but happen in Latin America. I remember during 3-4, almost 6 months, there was no material to do embolization. And the patient would come. And I started to do without embolization. And I saw that my result was better. Wow, what's going on here? And I saw that the tumor was easier to remove, was softer. See? And I learned from the wrong way how to do that. But as I think it's helping a lot. Embolization is good, but use with criteria. It needs to be a guy that is trained for do this. I don't know how it is in your country, but in many places in Brazil, the guy embolized in the morning, kidney at noon, the liver afternoon, brain. Cannot be like that. Has to be somebody that is totally dedicated. See, neuroendovascular. It should be neurosurgeon.
Yes.
Should be neurosurgeon that know that the possible complication that will happen.
Yeah.
See?
Nerve damage. Yes. And another thing is that, Professor, you use graft for the facial nerve and did only use glue, and you got very good results. But did you specifically position those grafts in a like they were twisted also, and it was you use very simple way of putting the graft. Like whenever we do nerve grafting, we try to keep the graft in a straight way and avoid the twist in the graft so that the neurotization occurs in a linear manner. So, but I was mesmerized with your results of facial recovery, even after putting the simple way of graft and doing glue. So how's your experience? Like you learned it with your experience, or you are?
No. What I did in this case was invaded just in the mastoid segment.
Okay.
See, of the facial nerve, and the nerve sheath was preserved.
Okay.
You see, and I kept the nerve sheath.
The inferior.
And I had distal and proximal, and the sheath between. I just put over the sheath. This is a special situation.
Okay.
And the majority of the time, you need to make to give a stitch one side, a stitch to the other side, and glue.
Yeah.
See, and try to keep the best anatomical position. The problem is that when you put the flat back, they move. Do you know what I do? I put fat down, fat up,
Sandwich.
try to protect the nerve in the middle.
Sandwich like, yes, yeah.
See, like the sandwich, because when you put back, the nerve will go to everywhere.
Yes.
It'll be like that, it'll be confused. But you never know what will happen. But I try to protect. You are completely right. You're completely right.
Thank you. Thank you so much, Professor. Thank you.
Okay.
Thank you. We have a question from the chat by Dr. Harshad Parekh. In case of glomus, when you remove the tumor and anatomically preserve nerves, in the postoperative course, do you find any paresis? If so, then how long does it take to recover?
Okay. The very important thing is, if in the pre-op the patient has deficit, the post-op will be okay, because there is a compensation. I say that, and I don't know if it's true or not, but you have 75% from this size, 25 from this size. If the tumor starts to grow and go eating the nerve, the 25 from the other side, you go 24, 5, 5, 6, and compensate. And you have pre-op deficit, you do surgery, post-op will be okay. You can cut the nerves. There is no problem, because there is compensation to the other side. In acute, it's very difficult situation. Very difficult situation. If you have acute deficit, the majority of the patient need gastrostomy, not tracheostomy, but gastrostomy, the majority of them. See? Tracheostomy may be very short time, but gastrostomy may be sometimes need 3, 4, 5 months. Okay? But tracheostomy, no. It's difficult to know who will recover. See? The time that you recovered. I'm telling you here, I pray here, they say that is really true. I don't have any patient with jugular foramen tumor, okay, with gastrostomy or tracheostomy, because there is this compensation. I have foramen magnum meningioma with gastrostomy. I have intradural lesion in the jugular, in the foramen magnum, see, in the jugular foramen with gastrostomy. But glomus jugulare tumor and tumors, the jugular foramen, that the nerve are compressed, they recover. I think there is some deficit already that we couldn't find in our pre-operative exam. See, but how long? Gastrostomy is good, eh? Gastrostomy is good. You take the nasal tube out, there is no sinusitis, it's clean the face. Gastrostomy is okay. Tracheostomy, no. Tracheostomy. Okay.
Thank you, Professor Borba. I also have a couple of questions. You mentioned about vagus nerve paraganglioma, and you said that we must be more patient in this kind of tumor, and you said we have to wait. So my question is very simple. How long do you wait? How can you understand that it is the time to remove the tumor is come? Is it a matter of size? Can you have some MRI parameters to understand that the nerve has been eaten already and compensated by the other vagus nerve? How can you decide the correct timing for removing a vagus paraganglioma? And the second question is about ICA paragangliomas. You showed a nice case of a big tumor. The question is, in your experience, do these tumors infiltrate the carotid artery wall, or it's just a very close relationship, but we always can find a surgical dissection plane and border to remove these tumors? So how often do you have to deal with breaking in the carotid artery?
Yeah, good. Let's start with the vagus. The vagus, there is no relation with size and deficit. See, sometimes we have a small tumor with deficit, sometimes we have large tumor without deficit. Okay, I wait until there is some compensation. How you know this? You can do EMG. See? EMG from the laryngeal nerve, the same EMG that they do for lateral sclerosis and ALS. See? You can follow with EMG. You see, there go the deteriorating. You see, compensate to the other side. It's very difficult. It's very difficult to convince the patient and to not do anything. Because there is somebody in the corner that you say, oh, no, give you radiation. It's very easy. The guy said to give you radiation. The correct time when you have the deficit, you start to have the deficit, and the patient was swallowed, okay. They start like that. They start to cough, to have some difficulties, and after that, the difficulty disappear, and they swallow, okay. Now you can do surgery, okay? Now is the time, not before, okay? I think this is the time. And the other point that I see, what accelerates this deficit is when the tumor starts to reach the jugular foramen up there. Maybe looks like the tumor is stretched by the bone, you know? You have accelerate more the deficit. When it's in the neck, the majority of time has no depth. But it's difficult to talk with the patient. It has to be very good relation with the patient to explain the situation about that. Carotid body. I was thinking, I don't have so many cases of carotid body. I have, I think, 34, 35, no more than that. Okay? I was thinking that in every case, I could find a plan. Until I have one case. I went to Uruguay. To do a case. I saw, they sent me the image, typical carotid body tumor. Large, the vessel displaced, see, in the tumor growing in the middle here. Good. I think I go there, do the surgery, put the money in the pocket, and come back. Man, the ICA was completely invaded. And I couldn't resect. And I did remove maximum that I could. I left a piece around the tumor. And the idea now in this situation is to put a stent and maybe irradiate, or probably I will come back to remove after the stent in the ICA. The same idea that some ENT in Italy, they use for glomus jugulare tumor. They put the stent inside the ICA and follow the ICA and remove the tumor with the stent inside. But the carotid body is different because you can mobilize. Mobilize from one side to other side. Let's see, you can get. It's not often, it's not frequently that you see this invasion, but it's possible. There is one pattern of vascularization that is different. They have vascularization from the ICA in this case that I saw. It was different tumor. I don't know, it was the same carotid body. The carotid body has vascularization from the external carotid artery, not from the internal carotid artery. See? In this case that I had problem, had it in the ICA. Maybe the pattern of vascularization, the pre-op, can help you to say how will be the behavior of the tumor. But surgery is surgery. Every case is different.
Of course, yes. Thank you very much, Professor Borba. Is there any other question for Professor Borba?
If I can, just one question about dural closure.
Yes, Ricardo.
If I see correct, you use a lot of fat graft to close it, right?
Yes, and fascia lata.
And fascia lata, okay. It's just what I want to ask.
Yeah. There was a video, I was going too long at this. I put first fascia lata, okay, inside.
Yes.
Okay, I tried to give a stitch in the dura, it's impossible to close watertight. Just you and me, Ricardo. Okay, it's impossible. It's just for the presentation. The people close very nice, have one case, make a picture and show presentation. It's impossible. Maybe one case in my life. Okay.
Okay.
You put inside. You approximate the max that you can. Always there is some space. Put another layer outside like a sandwich.
Okay.
Glue, fat. Put the ear back. The scrub over here. Close like that. If it's a very large defect that I cannot close, I put the lumbar drain, but I didn't open. I don't open the drain. I keep the drain here, and the trick is to put the lumbar, the catheter go out and come here, and the bagging will be here, not in the bed. The Brazilian patients are very unquiet, you know. They go to the bathroom and take the bag together. In one night can drain 300 cc. I keep the bag in the patient here, in this side here, and close. The other day, I do a CT scan. I do CT scan in the post-op. Before I go to ICU, I do CT scan in every patient, every craniotomy, independent craniotomy. Go to the OR, to the CT scan, to the ICU. In the other day in the morning, I do CT scan. In this case of jugular foramen is large, you see. If there is pneumoencephalus, keep close. If there is no pneumoencephalus, I open very high, but just a little, just to release the pressure and to drain a little bit. If you have in your country the safeguard that you can control the draining, you can drain maximum per day 50 cc, 50 to 100 cc, no more than that. See? Because the idea is not the amount of CSF that you take, it's to release the pressure. If you release the pressure, here will be okay. Okay? I had the worst complication in my life. One case, CSF leak with infection. What do we do? CSF and how to say pus? How to say pus? Pus. I want to cry. What I did? Lumbar drain, drape every day, and patient. The time will close. Time will close. Okay?
Okay. Thank you.
I'm telling
you very much.
All my complication here.
It's good to know.
I'm sorry, I have to disagree with one thing, Professor.
Yes, go ahead.
Because I am a huge fan of Lionel Messi, so I couldn't agree about Brazilian team.
Let's see last November. Let's see last November.
Okay, let me see.
You know, let me tell you one thing that's very interesting, very important. The Brazilian team has the best players. Best players. The best team will have one Brazilian that is very good. When you put together, it's the best team. But we don't have one leader.
That's true.
Everything that you do, you need one leader, somebody that will be ahead. This is our problem. In life, it's like that. You can have the best neurosurgeon in the world, but you need one leader that the people respect and follow. This is life. I think Professor Cato knows very well this because I had Professor Cano, the great leader. See, now I have you as a leader. Okay? Bad luck for you, Ricardo. Bad luck for you.
Thank you. Thank you very much.
Thank you very much also for this life lesson, I would say. And let's see about the World Cup. Unfortunately, in Italy, we have just to be, people.
You'll be on TV. You'll be
Yeah. We just lost our team, so we don't have our team this year. So very sad, very sad. Anyway, let's go ahead. Thank you very much, Professor Borba.
Thank you very much. I'm sorry,
great,
I have to leave. I have to go to the OR. There's a patient
Sure.
waiting me there.
Thank you very much.
See you soon around the world.
Sure.
Or in April, I will be in Japan. Okay. Bye-bye.
Thank you. Bye-bye.
Ciao.
And I think we can move on with the second speaker. Please, Ishu, do you want to introduce our second speaker?
Yeah, thank you. Thank you, Alberto. So I would like to introduce our next speaker, Dr. Alessandro Boaro. He is a handsome neurosurgeon from Italy. He has passed his neurosurgery from University of Padua. Currently, he is working as neurosurgeon at University of Verona. And he has done his clinical fellowship in spinal neurosurgery from Harvard University and computational neurosciences from Harvard University. He has published 24 papers and published 4 book chapters, and he has keen interest in artificial neurosurgery, and he is currently doing spine surgery and also functional neurosurgery. So today he will be speaking on artificial intelligence in neurosurgery from diagnosis to follow. So I would like to welcome Dr. Alessandro Boaro to present his presentation. Please.
Thank you very much, Professor Bishnoi. Thank you again for having me. To you, to Professor Kata and Professor Feletti, it's really an honor to be here and the privilege. It's going to be difficult to keep up the interest after Professor Borba's presentation, but I'll do my best. And also, I'm not going to comment on the Italian soccer team because, as we saw, it's kind of a bad moment for us. So I'm going to share my screen. Okay. Can you see my screen now?
Yeah, visible.
Okay, perfect. So this is what I'm going to talk about: artificial intelligence in neurosurgery from diagnosis to follow-up. There you go. When we talk about artificial intelligence, we are really considering a very big research field that was born in the 40s. And basically what it's trying to do is to have machine use available information to solve problems and make decisions, just like we humans do. And when we think about artificial intelligence applications that can be used in medicine and other fields, we really have to focus on specific techniques and the subgroup of them, which are defined as machine learning. And when we consider machine learning, we have to really consider 2 different ways in which we can have this algorithm, these models to learn from data and to provide insights and information, which are the supervised and the unsupervised learning paradigms. The supervised one is basically you have the supervised learning when you provide the machine with both the input and the output, and the machine is going to figure out by themselves the rules to go from the input to the output. So in this case, we already know the answer. We have to teach the machine to provide the information to the machine to learn how to do this connection. And we have the unsupervised learning, like for example, clustering algorithm, in which we just give the input information to the machine, and the machine is going to provide an output which is going to make sense to the machine. And then us as researcher, we have to understand why is that and what the machine actually was able to figure out. And so when we consider the application that could do into clinical work, we really have to focus on the supervised learning because we want to develop these models in order to be useful for us. So we have to know the answer to the problem that we have. We just want to have these models and machine to help us in doing a better job. And when we talk about machine learning, we cannot talk about big data. And when we think about big data, we really have to think about these first 3 features in considering data that are in high volume, that are produced with high velocity and have a high variety in nature. And these two elements, again, go very well together, because the more data we have, and we'll see later some nuances about this, the more data we have, the better we can have models understanding what is behind them and providing more precise answers. And so if we move the focus into neurosurgery, we can see there is a lot of different types of big data, from the radiological imaging, histological and molecular data, the simple free text that we have in the electronic medical records, neurophysiological data, data from personal devices that has been devices that we all carry around and that are very diffused in the whole world's population. And why should we try to use and develop these models in neurosurgery? We can use them to do repetitive and time-consuming tasks in order to, for the clinicians, for the humans, to be able to focus on more meaningful activities. We can use the computational power to try to anticipate, so to make prediction about possible complications or outcomes in order to tweak our surgical and medical strategy. And with regards to navigation and training, to try to ever improve the precision and accuracy of our surgical gesture. So really, when we think about artificial intelligence application in neurosurgeries, these can span into all the phases from diagnosis to training. And I'm going to provide you a little bit of an overview through my research work in these first three: diagnosis, treatment, and follow-up. So with regard to diagnosis, I'm going to talk about the project that I've been doing when I was in Boston, which consisted in a model, in an algorithm to provide meningioma segmentation from MRIs images. Meningioma segmentation is useful because we can use it to develop a preoperative plan and also to follow patient over time and to see precisely how much the tumor is growing. But as for now, is a time-consuming task, which is subject to inter-rater variability, and it's not even used all the time in all the centers because of these shortcomings. So we decided to use a very powerful machine learning approach using convolutional neural networks, which are a subtype of model, which turn out to be very good in both classification and segmentation tasks. And so we put together a data set of more than 800 MRIs from the Brigham and Women's Hospital and the Mass General, and with a total amount of almost 1,000 different meningiomas located in different parts of the head. And then we had expert radiologists and neurosurgeons to label this data in order to provide a ground truth. And then we use this ground truth to train an algorithm and to test it to see how good it was in segmenting this tumor and how close was the segmentation to the one produced by the human experts. This is just an example in which you can see in the center left and center right the comparison between the human expert doing the segmentation in these two different tumors and the prediction of the algorithm, which is just through a simple visual image, very good. If we look into the actual data, aggregated data, we can see that the DICE score, so the performance, the segmentation performance of the algorithms, is around between 85 and 90%, considering the mean and the median, compared to what the human expert is able to do. And when we, I don't have an image here, but when we compared the segmentation performance with the inter-rater variability of different experts, it was around these same values, which means that if we have 3 human experts doing the same job, the differences between these is around 10%. So the algorithm was able to do an almost human level performance job. And it was actually very good also in just estimating the volume of the tumors. As for now, when we try to estimate the volume of a tumor without using a segmentation, we basically use basic mathematical functions to calculate the volume through the diameters that we can have, that we can extract from the lesion. And we can see that we tend to, for both the 2D or the 3D estimation, we tend to overestimate the value of the tumor, the volume of the tumor, while the algorithm was actually able to have a pretty consistent and good performance in estimating it. And then obviously when we think about the segmentation time, it takes time for experts from radiologists to neurosurgeons to produce this segmentation, which in case of the automated segmentation of the algorithm, this time basically goes down to 0. Then if we go into the treatment phase, or better into the intraoperative phase, and we think about a technique that we use a lot here in Verona, but in general, it's gold standard, the intraoperative neuromonitoring. We know this is a gold standard technique to make sure that specifically for MEPs, which is the core of the project I'm going to talk about, to assess the functional integrity of the motor pathways while doing surgeries. And the interpretation of these signals, it's really based on macroscopic changes. But when we think of MEP or in general of a neurophysiological signal, these signals are quite complex, so they carry a lot of information. And we know that the machine learning, different machine learning techniques has been successfully employed to characterize different types of biological signals. So they're actually able to extract meaningful information that we can then use to improve our ability to make surgeries safer and more effective. And so we started with a very simple objective as a pilot study to try to use machine learning techniques to classify different muscles based on intraoperative MEPs. So we collected 3,300 MEPs from a total of 11 patients. All these MEPs were obtained using direct cortical stimulation protocols, and we considered a total of 6 different muscles, 3 from the arm and 3 from the leg. We then had, again, the expert, the neurophysiologist in this case, to evaluate these signals, making sure that we were removing the noisy one or the ones that were not very clear. And we then produced 2 different data sets. The first one in which we had the whole signal, and the second one in which considered the signal without the latency in order to make things more difficult, as latency can be very informative to distinguish between muscles. These both datasets we then had represented in 5 different ways, as raw or normalized signals, as a set of 8 clinically meaningful features, and then we used a mathematical approach to extract and represent these signals as a set of 7,000 features, and as a subset of 20 most meaningful features. We then defined the tasks. So we decided to have 2 different tasks. The first one, to try to train and test the algorithm within the set of muscle of the same patient. And then to make things more difficult, to try to train the algorithm on a subset of patient and test it on a different patient that previously wasn't seen by the algorithm itself. First, trying to maximize the number of patients and then the number of muscles, because we couldn't have signals for all the muscles for all the patients. These were the different types of algorithms that we tried. So nearest neighbor, KNN, support vector machine, the random forest, and 2 different types of discriminant classifier, one linear and the other one quadratic. And these are the results. So for the intra-patient task, you can see in these tables on the x-axis, there are the different models that we tried. On the y-axis, the different representations of the signal signal that we had. And you can see the performance in the table of cells of the different models in classifying the different muscles. And the darker the blue, the better the performance. And you can see that here there is a lot of dark blue. All the models, with some exception, were quite good in recognizing the different muscles within the same patient, with very high results specifically for the random forest model and the feature extracted representations. Moving towards the more difficult task in having different patients involved. In this case, we had 9 patients and 2 different muscles. Again, there is some dark blue, so we have high performances again for the random forest in both cases, so both using the whole signal or the signals without the latency. But we can see that for the other classifiers, things start to be more difficult. And things get even more difficult if we increase the number of muscles to 4. And in this case, you can see that also the random forest model that used to perform so well up until now start to have some real difficulties, which makes sense considering that now we only have 5 patients to test the model on. And so in this specific project, testing these different models, we could see that the random forest was the one performing the best performing algorithm, and that the feature extraction approach allowed the best classification results, meaning that the machine was able to use mathematically acquired features to have a high performance, which makes sense because the machine looks at the signals, but it doesn't look at the signals the same way we do. And then the latency, as was suspected, plays a significant role in trying to in the classification ability of these algorithms. Then if we move into the follow-up phase after the patient had surgery and is gone home, we have to talk about digital monitoring. So as for now, we live in an era in which digital devices, smartphone, smartwatches, and smart bracelets are very diffuse in the population of the whole world. And these devices are able to produce a great quantity of devices like smartphones, pedometers, and smartwatches. Okay. To provide a lot of data that can be used to solve which problem, to try to fill a gap between the real life environment in which patients live every day and the way in which we acquire information through interviews and prompts just in a few moments in time. And so this information gap could be filled using these new technologies. So we decided to try to use the smartphone GPS data to characterize the mobility of patients undergoing spine surgery, with 2 main objectives. One, to actually use the GPS to characterize the mobility of this patient from before to after the surgery, and to try to correlate this GPS data to the prompts data, which are the gold standard, to see if we can, in a way, start to validate this smartphone as follow-up tools. So we prospectively enrolled a surgical patient with spine disease. We followed them for a total of 7 weeks, and we acquired GPS data through their own personal smartphone through a dedicated application. And also we acquired these prompts through the same application, sending the prompts to them. What are the data types that we acquired? In terms of GPS, we obviously had a set of coordinates, and we translated these coordinates in some specific variables. So the time spent at home, the number of locations visited during any given day, the time spent in these significant locations, and the time spent moving or not moving during the day. With regards to prompts, we had the pain scale, the VAS, and then we had the ODI score, which provide a measure of disability of these patients. And then we have the PROMIS physical score and mental score. So physical is about their physical performance, mental is about the mental health of these patients. And we decided to provide two types of analysis: a segmented regression analysis to evaluate the change in the data trend of these GPS variables before surgery, in the perioperative period, and in the recovery phase, and then to use a linear correlation approach to see if in the recovery phase there was any correlation between the change in the GPS features and the prompts reported subjectively by patients. This is the population that we had. We had in total of 39 patients, with most of them had herniated disc, but you can see there was quite a variable set of diseases involved. Overall, we could see that with regard to the segmented regression analysis, there was a significant change in both in the GPS and in the prompts trend towards before the surgery and after the surgery, and you can see it very well here. So on the x-axis, you can see the days from the surgery, which is set by the red vertical line, and you can see that both for the time spent moving and the number of locations visited, they initially drop after the surgery, because obviously the patient just stays home and try to recover a little bit, and then towards the weeks, with the weeks, you can see that progressively improves and change directions. Same thing with actually the different things for the prompts, meaning that both the pain and the disability in which the patient find themselves progressively goes down after the surgery, showing that they actually the symptoms and the problems that they're having progressively get solved. Again, for the physical performance score, we could see an improvement, while it was interesting to see that for the mental score, that you can see on the right, there wasn't really a big change. And finally, we take a little fast look at the correlation between the GPS features and the prompts. In this case, we have the time spent moving and we have the pain. As you can see, the pain in the blue empty circles progressively goes down after the surgery, while the time spent moving progressively goes up. So there is an inverse correlation, which makes sense. The less pain, the better the pain the patient is, and the most it can move. Same thing with regard to the number of locations visited, and on the other hand, we can see that while the more time the patient spends moving, the better the physical performance is, and this again could be depicted by the data we had. Some of the limits and risks. In general, we have to consider the risks. In general, we have to consider the risk and the limits of these types of technology. Some limitations regards the fact that the computational power and the storage space available have some limits, and there are some related costs to be taken into account. The data quality is important because, as we saw, supervised learning means that we give the input and the output to the machine, and that is what is going to learn. But we have to make sure that the quality of the data that we provide is good, because otherwise the machine is gonna learn from bad data. And as for now, there's not still a great interdisciplinary collaboration, which is mandatory to understand what's going on. And in terms of risks, obviously, we have to consider that we can't rely on just machine output avoiding critical thinking, specifically when we think about medical applications of these techniques, and that we have to be sure that we are answering scientifically and clinically relevant questions, which is not always the case. And we also have to consider the data sharing privacy issues. In terms of future direction, there are a lot of still to be done. This is just the beginning, and we have to try to really tackle the most important problem and do it in a systematic and informed way. And so, in order to try to provide a little bit of a guideline for this in the humans chapter that we wrote about artificial intelligence in neurosurgery. We provide a guideline on how to build, or at least to have an idea of how to develop a machine learning and artificial intelligence project, and which type of techniques to use depending on the question that we ask. And we are now conducting a survey about artificial intelligence in neurosurgery, in trying to understand what is the current knowledge, the interest, and the perspective of neurosurgeons around the world about the artificial intelligence, the applications, the risks, the concerns, in order to know what is the basis and how to start building from it. Thank you very much for your attention.
Thank you, dear Alessandro, for such a nice presentation. So I would like to ask, if any questions, please ask. If any comments, please.
I think you're muted, Professor Bisnoy. I can't hear you. Maybe it's me, though.
No, we can hear
No, I think it's me.
Maybe, yes, you have a audio problem.
Can you hear me now?
No, I can't hear you.
Alessandro?
Can you hear any one of us?
Probably he cannot hear us.
Yeah.
I can't hear you.
Let's see if we can fix the problem.
That can only be corrected by his laptop, not by us. Because
Okay, I am contacting him through WhatsApp and try to fix this problem. Okay, he's reconnecting.
Mm-hmm.
So maybe in 1 minute.
Yeah.
Anyway, it was a very interesting topic, probably something we will deal with in the near future. Often and often. I don't know if at your institutions you have any experience of artificial intelligence use, or
not yet.
Not yet. Yeah, I think there are some devices under developing, like navigation with CT scan integrated, that are working with artificial intelligence. So probably this will be a huge help for all of us in the near future. But maybe if Alessandro is able to reconnect, he can tell us what's the state of the art, I would say.
So Albert, so maybe I think AI tell us how much we can remove the tumor, or maybe such kind of the prognosis before surgery, I think. So that's very interesting.
Yes, I agree. I think nowadays, right now, the most powerful, value of this kind of resource is in diagnosing and mainly in follow-up. So actually, artificial intelligence can help us in detecting the residual tumors, or how much a tumor is increasing in time during follow-up. So this is much easier for artificial intelligence than for radiologists. Also, it's a time-consuming activity for a person, but for artificial intelligence, it's really immediate. So probably right now, this is the major indication. Okay, I think he reconnected, but I cannot see him. Yes.
So any other comments? Dr. Kapil, would you like to say something?
I think Alessandro.
Okay.
Yes,
Can
he's
you...
back.
Okay, I can hear you. I apologize.
Yeah.
I don't know what happened.
No problem. No problem. We were just commenting on your wonderful presentation about an interesting topic, which is actually cutting the edge area in neurosurgery. And with Professor Cato and Professor Bishnoi, we were commenting about the current use of artificial intelligence. So probably it's mainly used right now for follow-up or diagnosis, probably less for treatment, but we would like a comment from you about this.
Yes, and it's actually true because, as I was saying initially, just with a few words with Professor Cato, as for now, these algorithms can be very powerful, but in some instances, it's not really clear what is going on behind the curtains. And while this is less important if we consider a tumor segmentation algorithm, because we're always going to have a surgeon or a radiologist to check the exams to make sure that it's good for the OR, it's good for navigation, and again, also for the follow-up of patients. It's more difficult when we consider, for example, the work about the intraoperative neuromonitoring project, in which this was just a pilot study, but thinking about to having a machine to provide a real-time information that can be used to change a surgical strategy, we first need to understand what the algorithm is actually seeing and why is providing that particular results. So to answer the question, for some of these some of these models, these approaches, there is already a way to put them in clinical practice. For some others of this, it's gonna take some time, and there's gonna have to be an important conversation about the ethical elements of it in order to make sure that we are using trustworthy algorithms, and to make sure that the responsibility of using this algorithm is fall in the right hands. Because if we have an algorithm telling us what to do, we have to know why is that. Because we can just, if we make a mistake or there is a bad prediction, just say that the algorithm was wrong and that's it.
Yes, actually, there is always a responsibility by a doctor behind artificial intelligence. This must be very clear. Anyway, I think your study about meningiomas and segmentation is very nice, and I think it's possible to extend this kind of indication. For example, I was thinking issue, and Professor Yoko Kato and others.
Alberto, may I interrupt?
Yep.
Yeah, just I wanted to it was a very good presentation. For the endovascular arm, for the stroke treatment, there is one AI related software that is called Rapid AI. For that means whenever patient is in window period, up to 4 to 6 hours of the onset of the ischemic stroke. In that case is either we do CT or CT with DSA, or MRI or MRI with MR perfusion. In that case is for the diagnostic as well as therapeutic purpose. This software gives a very good insight and result. Means sometimes it happens that penumbra is more of a size, but clinically patient is very good. So clinical and radiological mismatch is there. How to treat and how to move forward. In that case is this Rapid AI. I think so. In the US, it is the only approved AI for the stroke treatment, and that helps a lot. In my city, we have where I am attached, we have that software. We use in difficult cases that how or to make precise judgment that if I do mechanical thrombectomy in this case, then how it will means what would be the prognosis and what it would be after the mechanical thrombectomy. So it helps in that part.
No, thank you, Tushit. That's very interesting. So you use it in your clinical practice, and you have good results in your experience with this artificial intelligence software. Yes. Nice. Very interesting. Actually, I think I guess this is based on CT scan, right? As you said.
Yeah, means
Yeah.
even it has everything. It is like, the neural navigation data. You can merge with CT, angio, MR, MRI, angio, MR perfusion, anything you can
Yeah.
use.
Yeah. I was thinking actually it's possible to extend some kind of applications to control aneurysm growth. For example, for those cases, we don't give indication for surgery, for treatment in general. So it's always puzzling, right? How to follow up properly these patients. When is it?
More difficulties like you have many aneurysm in one patient, and we
Right.
have propensity of more of ruptured cases. So
Right.
to exactly pinpoint which one is the culprit.
Right.
I don't know whether we could. It is like
but it's, this technology is very promising. Maybe this can help, not solve the problem, but help for sure. Thank you, Tushit. Is there any other question or comment?
So just I want to ask Baro. Oh, thank you very much for the excellent lecture. So can you predict how much percentage of the coiling, such as the aneurysm, maybe that's through with the shape of the aneurysm, or what type of the catheter or coil itself, or with stent or without stent? So would it possible before the treatment?
So you're asking if we can predict how much volume of the actual aneurysm sac is going to be filled with the coil after 3 months, 6 months, 1 year? Okay. So I think it is, meaning that if we have enough data, meaning if we have enough CTAs and if we have post-procedural follow-up CTA, and we have the information about the flow as well, about the dimension of the vessel, we can definitely develop an algorithm with a certain performance and ability to predict that. The difficult thing in this project is to be able to acquire enough data. And specifically when we think about imaging, we're always thinking about 3D. Always, we in these cases we think about 3D images that bring with them a lot of information, and so we also have to have very powerful algorithm. And in general, the more data we have, good data, as we have always have to remember, the better results that we can have. And the approach, so I think it's possible, definitely. I think we have to have enough data to do that. And just like we've always been done with classical statistical approach, in which we have single center study, but then we have better, more reliable results with multi-center study. The same thing is with these projects. The more centers come together with their data in order to develop bigger data set that takes into account the variability of the population for any given disease, the better the results are going to be. So again, the power of this technique is to be able to see things that we cannot, because we're human, and our approach is not as systematic as this machine. And so we definitely can exploit this power to answer some important, meaningful questions, just the ones you just asked.
Samir, you want to say something? You want to add something? Amir, please.
I just wanted to know that the accuracy of these results, and I think they are still in pipeline, I guess so. Or have you reached to a point that yes, they are much accurate than what a senior neurosurgeon would predict, or senior neurosurgeon would do? And secondly, how do we initiate this in countries where you don't have any kind of infrastructure or any kind of facilities for AI?
So to answer your first question with regards to the meningioma project specifically, that one that I can talk about, we actually had a range of performances that was comparable to the one of human experts, because we always have to take into account that if we have 3 different radiologists or 3 different neurosurgeons segmenting the same tumor, we're going to have a certain amount of variability. And we measure that variability around 5 to 10%. In terms of the volume, and that's what we had also for the algorithm itself. Again, what we have to do is to understand what is that 10%. So for all the neurosurgeon, it's not going to be missing a piece of tumor because if near a vessel, let's say. But that might be the case of the algorithm, because the algorithm doesn't look at the MRI as we do. It just look at a set of tables of data. And so we have to understand what really the algorithm does. So it's true that for that particular project or for others, we have very good results. But again, and I will never be tired to underline this, we have to understand if the performance is good, why it is good, and when it's bad, why it is bad. That's going to make the difference. And in regards to your second question, we are actually working now with the MIT to start one of these multi-center projects, and the way by which a center with no capability in terms of AI infrastructures can take part in this project is to provide data. So because and obviously going on as also the computational power goes up and the cost of the data storage progressively goes down, this capability is going to be more affordable. But in general, to be part of this project, you don't have to it's not necessary for each center to have the same capabilities, but just being part of it, providing the data and enriching the data set is just enough.
Yeah, okay. Thank you.
Thank you.
Thank you. So any other question for Dr. Boaro?
Maybe Kapil?
I'm sorry?
Kapil,
Sorry,
you can ask something.
Yeah.
You can ask something,
Yeah.
because he is a newcomer.
Oh, okay. Dr. Kapil.
Yeah.
Hello.
Yeah. Hello. Good evening. It's all about this AI implementation in diagnostic and I may say intraoperative monitoring. So how far we are going in that?
How far we are from using the intraoperative one? That's the question?
Yeah, that is the question. And other thing is we are missing haptic sensations from everywhere. Means even though we use neuro navigation, there is no haptic perception by say. So do you think AI is going to help us in that?
So with regards to your first question, and specifically to the work that I'm doing, our work now is very pilot. We just try to differentiate between healthy motor evoked potential, and obviously even though the algorithm in certain cases was very good at it, there is still a lot of room for improvement, but there is a limited clinical applicability of this. It's going to be way more interesting, and it's going to be the next step of this project when we try to analyze the whole MEP cascade from the beginning to end of the surgery, to try to understand if there are features of the signals that we're not taking into considerations now that can better predict the outcome of the patient, and so maybe tweak the surgical strategy during a surgical operation. And I think for this is going to take some years. At least because of the variability between different patients and how the monitoring is put together in the OR. With regards to your second question, on one hand, I think augmented reality is going to be one way to really boost things forward in terms of, it's not really haptic in this case, it's more of an immersive environment. But just think of being able to know that behind a certain piece of the tumor, you have a big vessel, so you have a very eloquent structure, and that's going to change the way by which your surgical gesture is going to be more informed. In terms of optics, I never thought about it in terms of intra-operative tool, but definitely has a role in training. If we consider the powerful platform, virtual reality in this case, platform that are out there, there is definitely some room to provide young residents or even experienced surgeons to just keep practicing with the haptic feedback that can come from this platform. I'm not very informed about this, but there's definitely room, and there is definitely active research on them as well.
Yeah. Thank you.
Thank you.
Very good. Thank you very much. I think we can close this webinar here. Thank you very much to all of you. Thank you to Professor Ishu Bishnoi, my co-moderator. Thank you, of course, Dr. Boaro, for the nice presentation and discussion. Professor Yoko Kato, do you want to say some closing remarks?
Yes, not closing remark, but in Japan we had a endoscopic congress which was held last week. So in Japan, even in Japan, so the more and more exoscope is coming up. So especially the younger generation, some of them do not use the microscope anymore. So the exoscope is a replace of the microscope a little bit. Of course, they need some more, I think, improvements. But I think it's a time to less invasive and the minimally invasive era now. Yeah, and today we had a very nice lecture, especially Moro, the very promising in the future. AI is very promising the topics, I think. So maybe please you can invite your colleagues for our alumni the webinar, because so many nice lectures and topics. And I think that the next month will be the last one this year, Albert. So
yes.
so till that time, maybe please do your best. Thank you very much for attending today.
Thank you very much.
And
thank you, Ishu. I want to thank you also, Tushit. I see Dilshod, Dr. Liu.
You're very silent.
I was just joining later. That's the reason. Yeah. Thank you. Both of the lectures were very interesting, very productive. Yes.
You're right.
Thank you. Hi, Dilshod.
Hi, nice to see you.
Nice to see you too. Very good. So thank you very much to all of you, and we will see each other in 1 month for the last webinar of this year for Fujita Alumni Association. Thank you very much. Have a good day.
Thank you.
Very much again. Goodbye, everyone.
You should please take care.
Thank you. Goodbye.
Take care of the yes. Appeal. Thank you very much.
Thank you, Sensei.
Thank you.
Sensei. Take
Yes,
care.
Sensei.
Yes, Sensei.
Arigato.
Arigato.